Good afternoon, and thank you for joining us today. My name is Ashley Mangum, and I am the project manager for Kids Mental Health Pierce County, who is hosting today's webinar. If this is your first webinar, first of all, welcome. We're so happy that you were able to join us today on this wet and rainy Wednesday. But I think that we have some great information to share with the community. I'm so happy that you took the time to be with us here today. If you're not familiar with Kids Mental Health Pierce County, we are a coalition of people and agencies in Pierce County that are joining together to address the growing behavioral health crisis among school-age children here in Pierce County. We are dedicated to coordinating a coordinated responsive behavioral health system that serves the needs of youth and families at the right time and the best place and with the best outcome for every family. So since March, we've been holding these monthly webinars with the goal of helping parents and caregivers understand kids and families during the pandemic. Pierce County, like many counties across the state, are working hard to meet the growing behavioral health needs of both our kids and adults. We know that there's system fragmentation as well as access and workforce issues, and we want to be able to address that. And I think it's imperative that we continue to support our kids and family as we navigate through some of the most challenging times that we've had to face yet. While we know that there can be varying differences of what a crisis is, Kids Mental Health believes that a crisis is defined by the youth and family when the youth needs outweigh the existing resources within that family. So today we really want to talk about some of those existing resources, get you familiar with some of the signs and symptoms of a crisis, as well as who you can call for that additional support and what to expect when you access those services. So we want this to be as interactive as possible. You do have that chat feature. Go ahead and introduce yourself in that chat. While we have a panel of experts, you really truly as parents and caregivers are those experts. You guys work with these youth, you communicate daily with parents if you're a provider, and so we really want this to be as interactive as possible. So use that chat box to introduce yourself. You'll also see down there, there's a question and answer tab. Feel free to use that to ask questions, and we will definitely be answering them throughout the webinar, as well as have a questions and answers section after the webinar or after the presentation. So feel free to use that chat box to offer your own suggestions as well as asking any questions. And we're going to do our best to answer every question. We know that we're really limited for time today, so we're going to try to give as much education as possible. Please note as well that this is going to be recorded, so if for whatever reason you have to log out, you will be able to access this recording as well as all the materials on our website, which is kidsmentalhealthpiercecounty.org. So with that being said, I will transition to our first presenter today. So excited to have, and our first presenter is Heather Fonseca-Bailey. And just to briefly introduce Heather, Heather received her master's degree in social work from the University of Southern California. After graduation, Heather went to work in the community mental health, serving both adults and children, before finally moving on to dedicating her efforts to working with children only. Heather has worked with children in clinical and school settings. Heather has been at Mary Bridge since 2016, starting off in the emergency department before moving to the medical surgical floor as one of the inpatient social workers. I've had the pleasure of working with Heather in so many different situations, and I'm so glad that she was willing to present here today. And so I'm going to turn it over to Heather to give us an overview of behavioral health symptoms. So Heather, I'm turning it over to you.
Can you see me now, Ashley?
I can.
Perfect. All right, I'm going to share my screen. So I am Heather Fonseca-Bailey. I'm one of the inpatient social workers at Mary Bridge. I share my patient load with my partner, Kelly. And we have the honor of serving children that get admitted to the inpatient floor, whether they are boarding, waiting for an inpatient mental health bed, or if they are here following an ingestion. So one of the things that I did want to talk about today was the difference between typical adolescent development versus when a child is entering into a full-blown mental health crisis. Can everybody see my PowerPoint?
Yes.
Okay. So one of the things that I also do is I do teach mental health first aid, and this is a big portion of that as well. where we talk about typical adolescent development versus the onset of a mental health crisis for youth between the age of 10 to 17 or 10 to 19. This is typically one of the biggest questions I'm always asked by parents is, how could I have known if, when a child is here post-ingestion, I never saw this coming. So in our mental health first aid, we cover what does typical adolescent development look like versus the onset of a mental health crisis. And I'm just going to give like a brief overview of that today. So when we're looking at early adolescence, we really are looking at children between the ages of 10 to 13. They're starting to grow more quickly. They're going through some body changes. Changes in their body can inspire curiosity. For a lot of kids also, it inspires a lot of anxiety with them. In this age group, kids are also very concrete with black or white thinking that things are either right or wrong. Things are going either very good or very bad. If they don't get something their way, it can be like the end of the earth, that type of thinking there. And they also are starting to feel that increased need for privacy. When we move on to middle adolescence, which is age 14 to 17, the changes continue, and you see a lot of physical changes due to puberty going on. A lot of teens become interested in romantic and sexual relationships. Children begin to argue more with their parents as they struggle for more independence from their parents and to become their own person. And their brains continue to mature and change and to be able to think abstractly, and they're able to consider the big picture. There's always this constant struggle that's going on, and that's the struggle that's between the need for a child to stand out and be an individual versus their need to also be a part of a group. And what we always tell parents is to remember that sometimes that the symptoms of a mental illness can often mimic typical adolescent development during this time period. So some of the things that we wanted to look at is just some general data about mental health and mental illness in general. And when you're thinking like globally, mental health conditions account for 16% of the global burden of disease and injury in people aged 10 to 19. And more importantly, half of all mental health conditions start by age 14. Globally, depression is also the fourth leading cause of illness worldwide, which is a huge percentage of people given our global population. What I wanted to also take a look at is what we're looking at here is these are the median age of onset. And when we're considering the median age of onset, this is based on when an individual first admits that they're having issues. So for anxiety or disorders, the median age of onset actually starts at around age 11, at eating disorders, age 15, substance use around age 20, schizophrenia, age 23, bipolar, age 25, and depression, age 32. And a lot of people realize that that median age of onset for depression is quite a bit higher, but that's usually due to because depression also occurs significantly in senior citizens, which throws that median offset age off. So what we always tell parents to look at is how are these changes impacting the child itself? Is it impacting them in school? Are they struggling with their daily activities? Are they struggling in social settings? And there's all of these are risk factors that they look at, that we look at too when we're completing a mental health evaluation for a child, like stressful events, previous episodes of mental illness, brain injuries, medical conditions, hormonal changes. And I realize I'm going through these very quickly here, but this information will also be available in the recording as well. So when I talk to parents about the warning signs for a mental health crisis, we're looking at things like, is a child able to complete their average daily living activities? Like, are they not able to bathe or brush their teeth or comb or brush their hair? Are they refusing to eat, or are they eating too much? Are they sleeping all day, or are they refusing to get out of bed? We're also looking at, like, are they having rapid mood swings like these here, like increases in energy, or are they suddenly depressed or withdrawn? And this is when we talk to parents about really having an open eye for what the changes in their child are. Are they making verbal threats? Are they acting out of control or destroying property? Are they being cruel to animals or being culturally inappropriate with their language or their behavior? Are they hurting others, cutting or burning themselves, or doing other self-injurious behaviors? Sometimes kids this age are having episodes of psychosis where they're thinking that they're someone that they're not. They're hearing voices or seeing things that aren't there. And this is a big one. They show no or little interest in extracurricular activities. They have changes in friendships. They stop attending school, stop doing homework. Oops. And they may have facial expressions that look different. They have unexplained physical symptoms like suddenly feeling ill, having increases in headaches and stomach aches, and complaints that they don't feel well. So with those, we always want people to remember that they have to keep a close eye on their child, and remember that adolescent development also does mimic a mental illness, and you want to keep a close eye on what the differences are between the two. Are these excessive behaviors, or are they just going through the adolescent changes? And the difference between the two is really asking your child what's going on and having that talk with them. And with that, I'm going to hand over the screen back to Ashley.
Thank you, Heather. And Heather was our amazing mental health first aid youth trainer for Kids Mental Health Pierce County prior to us no longer being able to do in-person training. So once we get that opportunity to do that again, I hope that you are all able to access that training. It's a great training for anyone who's working with youth to really be able to understand some of those early signs of a crisis and what are some of those next steps. So thank you again, Heather, for that information. And I know that that was quick. We will make sure to upload her PowerPoint as well with this recording so that you can reference back to that. As I mentioned, we do have a little bit amount of time and we have a lot of information to share. What I hope is that we could do a longer training in the future to cover that more in depth. And so the next speaker I want to represent or introduce is Nolita Reynolds. And in Pierce County, we have a youth mobile crisis provider, which is Catholic Community Services. And Nolita is the clinical site director for Catholic Community Services, Family Behavioral Health Services. So just to give you a little bit of background about Nolita, she has 20 years in the mental health field. Her experience includes working with children and families, as well as multiple systems serving the poor and most vulnerable populations. Nolita has a passion working for those in need of emergent stabilization, as well as lifelong loving family connections. She has had extensive experience working in crisis services, family search, and long-term intensive stabilization. Technical assistance projects include youth crisis stabilization, family search and engagement techniques in several states. Currently, Nolita oversees one of the largest sites in the family behavioral health system to include 70 to 100 employees, several clinical teams providing the highest intensity community-based services. This includes crisis services, intensive in-home, community-based outpatient, juvenile court, and residential diversion and transition services. She is developing new supervisors and teaching new approaches in clinical supervision, crisis management, working with peer counselors, and family search and engagement. I'm so grateful to have Nolita here, and I'm going to turn it over to you for your presentation.
Hello, let's see if I can manage this technology. Okay, here we go. Okay, so hopefully that is working. All right, so I am Nolita. Like Ashley said, I pulled that bio from something a long time ago, so it's a little embarrassing to actually hear somebody read it out loud. That was a new experience for me. So a lot of people interface with Catholic Community Services, Family Behavioral Health through one of our three kind of primary services. For this presentation, we're going to be focusing on the crisis team, but we also have WISE and FAST services. So there's just a quick little write-up about kind of what the basics or criteria are to access those services. But for the crisis team work, and you guys are welcome to read it, and there's a contact information at the end if you want to reach out, and Ashley's always great at connecting folks if people have more questions. So where we like to start with the work at Family Behavioral Health is that our work is very much driven by our values about keeping youth and in the home with their family. We always work towards a community and a family solution. So when young people are presenting crisis, whether it's through the ED, emergency departments, whether it's at school, whether it's at their home, in any environment, our goal is always to work to get the child back in the home, because that's where they're ultimately going to get better. And certainly if a youth needs to go to a hospital for like a short-term acute stay, we partner with the ABHU or any of the other hospitals locally. So as soon as they're transitioning out, we want to work to get in the home. That's usually through our long-term services, but through crisis, the values are the same, that we do work with the whole family, we don't work in isolation, and we're looking for a family and a community solution. We do believe in being strengths-based and being very collaborative in our work. Because again, often it's going to take, when you have young people that are presenting and crisis, it's going to take a little bit more than a family's able to give at the time, because they're often pretty exhausted, have been through this. So we need to partner with other organizations, other natural supports, which can sometimes be very challenging, but to help keep that youth pretty stable. And while we do work in a strengths-based and solution-focused way, when we come, we meet the family, we get a sense of what's going on. We're always going to develop a safety plan out of that. And within our organization, we often talk about it as our least strengths-based document. So while we're looking at being very collaborative, solution focused, we're always laser focused on safety threats, because we are working with some pretty intense sets of behaviors. Probably the largest is self-harm or suicide attempts. And we tend to feel like that we are able to, in about 97%, a little bit of an arbitrary percentage of the time that a youth presents, that we're able to safely work with them at home and in the community, because we do have a number of things that we're able to provide. So when folks start off, these are sort of the very basic things. There'll be more questions that people have. I do have the crisis line number, because that's how our services are accessed, through the Pierce County crisis line. It would be the same for adult services. If it's somebody who's 18 and over, they go to mobile outreach. If they're under 18, they come to youth services. There's a few exceptions, because sometimes we do work with a couple of young adults or our other services. So we may have to call the crisis line and say, hey, if for some reason this particular person comes through, please go ahead and route them back to us. But for the vast majority, for new referrals, we deal with youth, and mobile outreach deals with adult. So certainly very basic information that we need to kind of get started. We certainly need to know what the presenting issue is, the location of the child, but sometimes you'd be surprised how challenging that can be to get that in the beginning. And we do ask for caregiver information, because, and one of the things that we do like people to know is, let's say there's a youth who's presenting, they're at their job and they're at school and they're saying, well, I feel like killing myself, but I don't want to tell my parents. If it's rising to a level where we're very much worried about their safety, we don't feel comfortable sending a youth home with an adult who's not informed about what's going on. Again, we're working through a lot of things to see what we can do to figure that out. There are times where there may be some safety questions about a particular caregiver. The vast majority of the time, that's not the case, but we do look to work through that so we can have the youth with a safe adult. If they're truly presenting with some high-level suicidal ideation or plans, and certainly for suicidal behavior and acting out, that we want to make sure that we have a safe adult who's able to provide that support. So this is just a little, very briefly, about some of the components of those particular services. We strive, our contract says we have to get out to the crisis episode within 2 hours. We strive to do it in under an hour. I mean, obviously there's an array of things that could go on. There's locations of youth, there's locations of staff, but we do strive to get there as quickly as we're able to, particularly sometimes when we're dealing with calls directly from EMS or law enforcement. We know they have a lot of time pressures, and emergency departments are overburdened as it is. And so if we can avoid a youth having to get transported there and we can safely respond to the crisis where they are, then we ideally try to do that. So that's something that we like for people to know in the community. And as I said before, if they're at school, if they're at a relative's house, if for some reason there's some rare occasions that we'll get the call from a caregiver in Pierce County, but the youth is located somewhere else, we can leave the borders of the county and go respond to them. We're able to do that. Or sometimes there's a youth who's from another county who lands in Pierce County. We obviously can't serve them ongoing, but we're willing to respond. So we're able as a provider to have a little tiny bit of flexibility with that. And one of the things that I think it's important for people to know, because a lot of times families come to us and people are like, no, they need to be detained. They need to be in a hospital. They're not safe to be out in the community. Again, we're going to look at what's going on with the youth and family, but there's a lot of times that we do feel like they can safely be maintained at home. Sometimes it may be an issue that they have to have a level of oversight. So a youth is saying, well, they took a bunch of pills, they presented at the ED, and they're like, I still feel like I'm not going to be safe. So we may talk with a caregiver and say, could they sleep in your room tonight? If we're worried about the youth, let's say leaving through a second story window, can we help do some arrangements in the house to have them in a safe space that you feel okay with doing? That you feel like you can safely do it. Now, let's say the caregiver's too exhausted. She's like, I've been up the last 2 nights, I can't do it. So we'll say, is there someone we could call? Is there a relative or a neighbor? Sometimes, because unfortunately with mental health services, there's still a lot of stigma. It's not the same as if you were in a car accident, although we try increasingly, I think as providers, to draw those parallels and truly present that this is a health condition. Sometimes they're like, no, I don't want to ask anyone. Ideally, we're going to try to work through those barriers, but if need be, we do have staff that we can deploy. Again, this is usually if it's a big safety issue, like you're needing 24/7 awake support. We do have the ability to do that. Again, the majority of the time we don't do that, but I only present our ability to do things so people understand why that we're saying we feel like we can manage a pretty acute situation safely in the youth's home. And a lot of times we do feel like we can do that. If we don't, we're absolutely willing and do and push and say, hey, we feel like they maybe need a short-term hospital stay. As you could probably see on the slide, we do have psychiatric services as needed. Sometimes we can get them in quickly for an emergency appointment, but I will say our providers, and you probably have heard this too, they're like, what is it that you think that we're gonna do immediately? Because a lot of times medications take time to work. Sometimes it does make people feel like, okay, I have a place I can go. And so we're willing to look at that, and they're all great clinicians, our psychiatric providers. And so they're certainly willing to be a voice of support, and especially around supporting safety. Also, you can see in here that we have things like lock boxes and door alarms. Again, we try to find solutions in the family's home because lock boxes can be smashed open. Our door alarms are pretty good about not being deactivated, but they can be pretty loud and noisy. And so we try to find other resources as needed. But we can even help with like changing, like let's say they need a locked room, we could actually bring new doorknobs out. We keep them in our office. And I'm bringing up those concrete supports, and it may sound silly, but sometimes something that small can be a barrier that can make a situation that may be manageable a lot bigger. And so anything we could do to remove barriers and focus on truly this mental health crisis, we try to do. So we try to remove that by having those types of things available. The interventions can run, they could be as short as an hour. Sometimes, again, all of us have responded to calls where we have an 8-year-old that's arguing with let's say they're arguing with their dad about unloading the dishwasher, and somehow that becomes a crisis. Dad calls a crisis line. Sometimes we can talk them through that and don't even need to do a face-to-face response. About 70–80% of the time we are going out in the field face-to-face, however, but it can be initially start off something like that, and then, or it can go up to 72 hours, sometimes even longer. Once we kind of get past that 72-hour mark, it's not a definitive stop or a contractual limitation, but we really need to be looking at, do we have to do like a brief, maybe a fast intervention, or something they need a little bit more than that initial stabilization can provide. And so we're looking at whether it's an external provider or something in our services. So just a little bit about that. And I will say, I don't know if people have questions about that. Certainly COVID, the last several months have put a different spin on the services we can provide. We are still out in the field as a crisis provider. We're trying to, if there's any ways that we can safely do telehealth, we have that as a part of our ongoing services. But just to answer that question, we are still doing face-to-face or crisis services. Everybody's wearing masks. We're being very mindful about temperature checks, asking family questions, but just kind of wanted to let folks know that. So basically that's about the end of the presentation. So I don't want to take too much time. I could always talk for quite a while about providing crisis stabilization because it is something I'm passionate about. There's contact information at the end, and again, the crisis line number. And that is the end of the presentation. Thank you, everybody.
Thank you, Nolita.
Absolutely.
And Nolita will be around for questions and answers. There's been some great questions and answers that have been coming through that question and answer portal, as well as some pre-submitted questions. And so all of our panelists will be here at the end to answer any additional questions that may come up. And so before I introduce our next panelist, you know, it's not too common when we think about our crisis system that we talk about a hospital. And I thought it was really important for us to highlight the use of emergency departments within our crisis system, because it has been something that we have seen being utilized on an increasing basis. And just to put that in a number perspective, we've seen a 400% increase in the amount of kids who have come to Mary Bridge for a behavioral health related crisis. And those numbers remain stable even through COVID. And so unfortunately, there are times where we have come into the emergency department and it's more likely that you're gonna see a kid there for a behavioral health related complaint instead of a medical complaint. And so I thought it was important for us to spend some time and hear from the team at Mary Bridge Emergency Department about what parents and caregivers can expect. I think sometimes there's some misunderstandings about what can be accessed from a hospital, what kind of services they can provide. And so I thought it would be helpful for us to just provide some education on what parents and caregivers can expect if your kids were to have to go to the emergency department for a behavioral health related crisis. So it is my absolute pleasure to introduce Julie Johnson. And just to give you a little background about Julie, Julie received her bachelor's degree in social work from Pacific Lutheran University in 1993 and her master's degree in social work from the University of Washington in 2002. She has been a social worker in the Mary Bridge Department for 18 years. Many people, including myself, have trained underneath Julie and got a lot of mentorship from her. So just so much knowledge and expertise there. Prior to working at Mary Bridge, she was an investigator at Child Protective Services for 10 years. So thank you, Julie Johnson, so much for being here, and I'm going to transition it over to you.
Thank you. It was so fun to look on here and see so many familiar names from previous work and working at DCYF, so it's nice to be here. So I just wanted to start it out by saying that, as Ashley said, we get so many kids in the emergency department for mental health issues. Sometimes they're self-presenting with their parent, and a lot of times they're referred to as from schools. I know there's a ton of schools on here. Schools, primary care doctors, outpatient counselors, they're sending them to the emergency department for a mental health evaluation. I just wanted to share that if you ever are someone who does send a kid to the emergency department, that it's helpful if you guys call ahead and talk to the social worker that's working. That way we know your concern. We get a lot of calls from counselors who are sending a kid in, and typically it's because, you know, maybe they want the kid to be an inpatient, or maybe they need to kick it up to Catholic Community Services, but it just helps us to know what you're thinking when you're sending them in. Okay, Ashley, next slide. So when a patient checks into the emergency department, they're triaged by a nurse and placed in a room as soon as there's a room available. We place them on what's called full precautions, which means we put them in a gown. All of their belongings are locked up, including their cell phones. We're actually have recently gotten into the practice of actually putting parents' belongings away as well. We just do it for safety reasons. And our thoughts on the cell phone is a lot of times it's social media or peer relationships. And it's just best to put that away while we're working through the crisis at that time. A doctor does come in and do a medical exam, and sometimes will require extra testing, but they're trying to make sure that there's not a medical reason to explain these symptoms. Next. So Mary Bridge is staffed with licensed clinical social workers 24 hours a day. We work with the family and the patient to try to determine the best plan for the patient by gathering background information. We have them complete a trauma screen. We have parents sign information stating that they understand the patient's rights for treatment. So the way we do it at Mary Bridge typically is once the kid is medically clear, a social worker will go meet with the patient and family and explain the process. We then will take the parents out of the room and talk to them in private. We gather all of their information, their concerns. They typically have a lot of knowledge about what's causing some stress for the kid. And then we meet with the patient in private to do our evaluation. The things that we're most focusing on is, their suicidal thoughts, if they have a plan. We have a lot of different ways to ask questions around what types of plans they've considered or ruled out. Sometimes kids will share that they have actually attempted and never told anybody. If a kid says that they've thought about hanging themselves, then we're going to go into more details. Have you put something around your neck to see what it feels like? Have you figured out what you would try to hang yourself from? Like, we try to gather the more details to see how close they are in to acting on these thoughts. And that's how we are determining the risk and what our discharge plan should be. We may have a kid that shows up because they ingested medications. So a way we would evaluate that assessment is, did you take the medication and instantly tell your parent, or did you instantly call 911 or post it on social media? Or did you take it and go to sleep and you woke up in the morning disappointed that it didn't work? Obviously, the second one is a high risk situation and one that would cause me more concern and consider a more, I would be more likely to hospitalize a kid like that. There's also some means that are more difficult to restrict. And so, I'm always a little bit nervous with the kids who say they want to hang themselves. I think that there's a lot of things that they can use for that. So those are just the things that we're trying to gather in determining what our best plan is. Once we complete our mental health assessment, we meet with the parents again. We are transparent with the parents and when we talk about what the kid's plan is, what they have done before it as far as past attempts. We feel like they're the ones that need to know what needs to get locked up, what type of supervision needs to be provided. And so those are the things that I will always share. I think a lot of the other stuff, what's causing the stress is the kids' private information, but usually the parents know most of the time for the most part. So go ahead, Ashley. So things that we do, sometimes we're able to just safety plan with the family, with the patient and the family. We can try to refer them to outpatient services. I usually tell parents that I have three options. One is if they're not in outpatient counseling, I'm going to try to get them connected to outpatient counseling. If they are an outpatient and it's not enough, sometimes we'll, actually frequently we refer to Catholic Community Services. They come out to Mary Bridge multiple times a day and safety plan with families and, continue to follow them to connect them to outpatient services or possibly wraparound services. And then the third option I have is hospitalizing a kid. One thing that we do have, I want to add, I'll leave you, go ahead, it's all right. The one thing I wanted to add that we have a newer thing at Mary Bridge, we have a behavioral health navigator who just started working with us within the last 6 months or so. And she is a case manager that we will ask her to bridge the gap. Sometimes, somebody has private insurance and they need to get connected to a psychiatrist or something. Our behavioral health navigator has access to their insurance and how to connect to the right people so that they don't slip through the cracks. So I wanted to share that. Go ahead, Ashley. So inpatient hospitalization. So it can be recommended when there's a medical necessity and that there's no least restrictive options that we can do to reduce the risk. I do want to share, there are pros and cons to inpatient. The pros are obvious, it's safer, there's, it's short-term stabilization, and they have access to medication right then. That's typically, obviously those are the three reasons why we would send a kid to inpatient. I think there's a lot of cons to inpatient, and my team talks with parents about this a lot. We have parents and kids coming in every day, coming in just to request inpatient. And so we do a lot of educating to parents about what the downfalls of that is. Some of them are that they're going to meet a new best friend or a new boyfriend in inpatient, and it's somebody else who's struggling with their own mental health. You know, the younger kids who aren't doing any self-harm and are just thinking about killing themselves and don't really have a plan, I'm not in support of going to inpatient. My worry is if you go to inpatient and you aren't cutting on yourself, a lot of times you're coming out and you are, because you're learning these new behaviors. You know, if you have a kid who wants to overdose and that's the only way they've ever thought about doing it, and they, you know, I share this with parents all the time, and they go to inpatient and they meet someone who's got marks on their neck and bloodshot eyes because they tried to hang themselves the night before. Parents don't necessarily want their kids to, you know, meet people and you know, because they're not, even the parents aren't there to supervise this, so they don't know what types of relationships are happening. And I have to say, during quarantine, the thing we've seen the most are these kids that have gone to inpatient and gone to inpatient, and they keep coming back. And I think some of it obviously has to do with the stress at home. You're stuck in home with just your family. But it's also a little bit like, in my opinion, it's like summer camp for the other kids that are struggling. I've heard so many kids that come in and say, that's the one place I feel like I belong. And I don't want that to be an inpatient unit for other kids, you know. So we try to avoid it if we can, but sometimes we do send kids to inpatient, obviously. So there are limited beds in Washington. The 4 facilities that we can use are Tacoma General has an adolescent behavioral health unit. People think that it's Mary Bridge. It's technically Tacoma General, but it's our sister hospital, so they do take a lot of our kids. There's Seattle Children's Hospital. They take all ages of kids, and they also take kids with intellectual disabilities or kids who are on the autism spectrum, where a lot of the other hospitals don't. Also, they're the only hospital that takes kids 12 and under. Therefore, it ends up being a longer wait while kids are waiting for inpatient at Seattle. If kids, you know, we try to, you know, 12 and under, I'm not a huge supporter of sending them to inpatient because I think they're so impressionable and they're going to meet older kids that, you know, have a lot of struggles as well. So we have Fairfax and Kirkland, and we have Smoky Point in Marysville. So those are the 4 facilities we use. When we recommend inpatient for a youth, if there isn't a bed available, the kid will stay in our emergency department, and we reassess them each day until a bed is available. So maybe a kid is waiting here, there's no beds available, they've been here a couple days and the crisis has seemed to pass. We try to do we try to work on a least restrictive plan at that time. So maybe the kid's like, I feel better, I didn't know everybody was gonna be so worried about me, I wanna go home, I wanna be with my family. So we do try, you know, if we don't need inpatient at that time, we'll send them home. But we've had some kids who are waiting for Seattle Children's have been here in our emergency department for, you know, 3 weeks waiting for a bed. And it's not a healthy thing for a kid to wait in an emergency department with no windows, no ability to go outside or anything. So we, you know, if we can work on a least restrictive, work with Catholic Community Services or outpatient, that's way better in our opinion. Okay, next slide. Okay, so these are the 3 ways that kids can be hospitalized. One is the adolescent initiated treatment, and basically that they're voluntary between ages 13 and 17. We get most of our kids tend to be voluntary. If they're kids under 13, a parental consent is all that's needed to get them hospitalized. But again, we try to avoid that if we can. We also, if we're recommending inpatient and the kids are like, heck no, you're not sending me, I'm not going, parents actually do have the right to sign their kids under family initiated treatment. It's obviously more ideal to have them go voluntary. I think they'll get more out of it that way. One thing to keep in mind though is we do get a lot of parents that bring their kids in, want them hospitalized, they want to do family initiated treatment. We complete the evaluation and they actually don't meet criteria, meaning, you know, the kid is depressed, they're sad, they're having struggles and stuff, but they're not suicidal. And no, I would never act on it. I would never kill myself. No, I would never kill anybody else. We would not pursue inpatient. And so a lot of that is, again, back to education to the parents, you know, that outpatient is what would be best for their child, and that an inpatient unit would not accept them based on this criteria. And then the last is sometimes we do refer to a designated crisis responder to have them assessed to be involuntarily detained. And we don't do that all that often at Mary Bridge because we have the option of family initiated treatment, but there are sometimes that we do refer to them. Maybe it's because a parent isn't capable or able to sign them in. So I'm gonna defer all that information to Adam and Todd, who are gonna be speaking next, but that is the gist of Mary Bridge. So thank you. Oh, Ashley, you might want to, I didn't read through this stuff, but this is, all of this information is going to be shared with you guys. The parts about family initiated treatment and accessing those resources, and oh, and the information sharing. When a kid is in the emergency department, we can share information. You don't have to, it doesn't require a release of information when a kid is in emergency department because we have to coordinate with outpatient services. So that's the whole information sharing law. I get a lot of providers who say, oh, I don't think I can share anything with you. Well, you can when it's for the sake of helping a youth in crisis. So thank you.
Thank you, Julie. And I know this is a lot of information. I did share a link in the chat box that has a link to a provider's guide to family initiated treatment, parents guide to family initiated treatment, and then that mental health disclosure resource as well. And those are just some great ways to be able to understand better, because I know it can be really complicated in understanding those laws, but those resources are available. So next, I'm going to transition to our next speakers. I'm so excited to have Adam Parker and Todd McFarland from our designated crisis responder team, or our mobile outreach crisis team. And so just to give you a brief introduction of Adam and Todd, Adam Parker is a supervisor of crisis services with MultiCare Behavioral Health. He is a designated crisis responder and has his master's of social work. Adam is a system thinker and works hard to bridge people to services available within the community. Adam has worked in behavioral health for 5 years and continues to work in crisis services. Adam is also the program supervisor for the growing co-responder teams, both regional and with the city of Tacoma. Outside of work, Adam enjoys being outdoors in endurance sports. Next, I have the privilege of introducing Todd McFarland, who is a seasoned designated crisis responder, social worker, and fierce advocate for patient safety and rights. Todd has over a decade of experience in crisis services and recently accepted the role of DCR liaison, providing the team and community with continued training and education on crisis services and involuntary treatment assessment process. When Todd isn't providing crisis services, he works with adolescents as a functional family therapist. Todd enjoys a balance of work and play and can be found hiking, traveling, and spending time with his family. I am so grateful to have Todd and Adam here, a wealth of expertise. Remember to keep those questions going. We will have questions and answers after Todd and Adam's presentation. I did see a couple of hands raised. I don't have the ability to acknowledge that, but if you ask your question through the questions and answers, we can get to it. So I'm going to transition it to Adam and Todd. Thank you.
Hi, welcome. Let me just get my screen up and going and we'll get going. Thank you for having me today. So again, my name is Adam Parker and I'm here with my coworker Todd McFarland. We are the designated crisis responders. And what that means is we do the civil commitments, the ITAs, the involuntary treatment assessments in Pierce County. Like Julie was saying, when a lot of the less restrictive voluntary options are unable to be fulfilled or the patient is so acute that they would need inpatient, we are called to step in and provide services. All right. So the designated crisis responder is the person who really has the authorization in the statute to do the investigations for up to 72 hours. Under 7105 for adults, in particular to the 7134 for adolescents between the ages of 13 to 17. We are the authority with the valid within the county to provide this designation. We also perform investigations for revocations of persons on a 180-day less restrictive or conditional release court orders, and that generally happens post detention. If an adolescent is released to the community on certain stipulations and is not doing well, we have the authority to send them back to inpatient for a potential duration of their order. We also provide a consultation to other professionals in Pierce County for persons with challenging issues. We file the subsequent petitions for 14-day commitments for individuals who are detained in community hospital settings, such as children's. We also provide expert testimony in the court regarding persons who have been detained. In general, when we come out, it's a very specific focus, and the focus is an investigation around risk. And so what that would also entail is just really gathering a lot of information. And I kind of spelled it out, but I can just kind of hit the high points. We just really need to know the individual's name, kind of date of birth, social security. If people call with that kind of position, the person make a referral, address, location, the individual be referred. In this cases, in most cases, it's generally at a hospital, so we'll gather that from the social worker. Any sort of witnesses, family, friends, neighbors, anybody who has direct understanding of really kind of what's going on with the youth in question. Maybe their current mental status of associated behaviors that could include delusional thoughts, thoughts of suicide, thoughts of harm, agitation, aggression, and so on and so forth. And the description of what a baseline would look like is helpful when they're not in crisis. So we can kind of compare and contrast to current presentation and any sort of like serious health issues that may require medical evaluation. We also do a brief investigation about their brief history. If they're potentially on a LRA, does the person have a guardian? Have they been contacted? Any sort of medications they may be on? Are they compliant with medications? Does the person need an interpreter? If so, what language do they speak? And if the person feels they need emergency psychiatric hospitalization to ensure the safety of the others.
Hey, Adam, are you able to get a little bit closer to your microphone?
Oh, I'm sorry. Can you guys not hear me? How's that?
It's just going in and out. Thank you.
Is that better?
Yes.
Okay. So, and generally for the grounds of the investigation, after referrals have been made, we tend to do a very thorough background, and we made prior history of previous involuntary commitments. The general laws with the WAC say 10 years. This can include patterns of deterioration, behaviors, and similar to prior episodes leading to a potential involuntary, any history of violent acts that include suicide attempts, aggressive to others in the past 10 years, and any known criminal history. Other information can be included to an individual's crisis plan or available treatment records. The main piece, I'm going to pass over to Todd, and he's going to talk about the main component of the questions to come, and that's the grounds for involuntary detention.
Good afternoon. So we're talking about the grounds for involuntary detention. When we come into a scenario where we're called in to do an assessment, we're looking at basically three components. We're looking at, is the person a danger to themselves? Are they a danger to others? Are they gravely disabled? And there's also, are they a danger to property? That there's been times when we've had to detain for reasons of that. But a danger to self, basically we're looking at substantial risk that physical harm will be inflicted by a person upon his or her own person, as evidenced by threats or attempts to commit suicide or inflict physical harm on oneself. Danger to others, pretty much what it sounds, physical harm will be inflicted by the person on another, as evidenced by behavior which has caused such harm or which places another person or persons at reasonable fear of sustaining such harm. Grave disability, that, so when we look at danger to self, danger to others, that's pretty clear cut. It's pretty self-explanatory. We've got the history and whatnot, but grave disability, there are basically two prongs that we're looking at when we're looked to somebody that is gravely disabled. Now, when we look at that, somebody that is gravely disabled means somebody that could maybe be delusional, maybe they're responding to internal stimuli, maybe they're having other psychosis symptoms. And so basically their mental health symptoms will impair them and not allow them to be able to meet their basic needs of health and safety in the community. So that's what we're looking at. But essentially, it means a condition in which a person, as a result of a mental disorder, is in danger of serious physical harm resulting from a failure to provide his or her essential human needs of health and safety, and then B, manifests severe deterioration in routine functioning, evidenced by repeated and escalating loss of cognitive or volitional control over his or her own actions, and is not receiving such care as essential to his or her health or safety. That was a lot, so I apologize. But basically, we're looking: can they care for themselves? Can they meet their own basic needs of health and safety? And sometimes when we're looking at kids, adolescents, sometimes it's not very clear. So that's where we do the investigation. We investigate to find out. We talk to the parents. We talk to whoever we need to talk to as part of our investigation to make a really good informed decision, because we're essentially looking at suspending somebody's rights for a period of 72 hours. And so we want to make sure that we have everything and that this person meets that criteria, because we're not only here to make sure that they're safe, but we're here to advocate for them, and we want to make sure that they're getting the care that they need. And sometimes they may not need involuntary detention, and we certainly want to honor that and make sure that they're getting where they need to be at that time. That's it. All right. I'll turn it back over to Adam.
Thanks, guys. And I'm sure there'll be if there's questions, we'll be here to answer them. I'm going to stop sharing and pass it back to Ashley.
Thank you, Adam and Todd. And I'm going to ask all of our panelists, Julie, Adam, Todd, Nolita, to come back for our questions and answers component. Fortunately, Heather had to drop off the call, but if you have any questions, feel free to use that questions and answers box. There's been some great questions that have come through so far. So one of the great questions that I saw come through the chat is, how are children's cultural backgrounds and beliefs taken into consideration when conducting assessments and providing care? Nolita, do you want to start with that question?
Sure. It's funny you asked that, because we're actually going through a process, actually starting with our employees right now to kind of revisit this, but it is something that we always try to ask, like even at the initial time of referral. Now, granted, when you're calling through the crisis line, it's not a question about kind of some cultural or ethnic background components, because they're on the phone. It's just, you're trying to get a crisis information that we ask about, but we try to do it right away to see what's going on. So in a part of our assessment, and if I had more time here, I actually would have gone through some of our assessment components that we do, but we're certainly looking at where they live, what their background is, what the family history, because there's even cultural things like dealing with families from rural Pierce County versus urban Tacoma is a very, very different experience. Because we also work in the field, it's something we actually have to be mindful of with our employees as well, because you go some places, like a recent example, there was families with Confederate flags in there. When they open the door and our staff are wearing masks, they're like, you're not effing coming in here with that effing mask. And it's just an example, and I'm not trying to stereotype, but there are definitely differences, and that's a subcultural component. And so it's something that we want to make sure that we're mindful of. We have a lot of immigrant families where there's things that we're looking at. And so one of the things about working kind of in a family and a community-based way, the more we can access those resources that are normative, the more it's about solutions that we help them come up with, and less about what we're imposing on people. I mean, we get into tricky scenarios, and actually I was just having to step away and take a call. Actually, something pretty horrible happened where there's some people wrestling with a firearm last night. Where families have beliefs about not moving firearms. I have a right, they have Second Amendment rights and things like that. And it's like, we don't try to argue with that, but it's like, again, our laser focus right now is going to be on safety. And sometimes we don't have a lot of information in the beginning, and we're very transparent about that. Right now, we're planning for the next 12 hours, the next 24 hours. Let us get through this, because we have to maintain safety, and we have to be more unwavering on that. But absolutely, again, looking at their context and their environment, and because we do typically work in their milieu, we're a little bit better able to access that. Like, even if it's looking at pictures on the wall, looking at who's present, we're able to pull that in so it does feel more normative and respectful for the family. And obviously we want to find that balance with being very mindful about safety that just we can't compromise on.
Thank you, Nolita.
Absolutely.
Next question, is the mobile outreach crisis team available for all of Pierce County? Just curious if your services are available on the other side of the bridge in the Gig Harbor Key Peninsula area. Adam, do you want to answer that?
Yeah, so the mobile outreach crisis team it services all of Pierce County within the boundaries of the, I think it's 1,200 square miles. When it comes to children, generally, if someone were to call that crisis line, the crisis line would route anybody 18 under to CCS for sort of immediate crisis support. And then most adults or all adults 18 and over would be go to MOCT. And then like Nolita said, we partner and kind of work with each other and support each other, how that can look, as well with Julie. And if in fact an adolescent 13 to 17 would need our services for involuntary treatment, then we would be contacted through more of a referral process.
Thank you.
Anywhere in the county. And I mentioned briefly, I'm a pretty fast talker, but if we need to like leave the county because of family that's connected to Pierce County, in like in the initial crisis or even after, is outside of those borders, we have the flexibility in our particular service to do that. And so we will go anywhere. And sometimes like when you're safety planning or looking at crisis responses, if you're somewhere like some of those places on Key Peninsula don't have great cell phone service, crisis response is a challenge because we can't get there in a timely way. So we have to help as a part of the safety planning, develop ways that we can help ensure safety because we just may not physically be able to get there to respond in person as soon as is needed. So we try to build that into any safety planning that we're looking at. And again, in those early days, if we're worried enough about it, we've actually had, this is an extreme example, so I don't want people to think this is the norm, but we've had people like stay in a hotel nearby because we just know that it's too touchy. We're trying to do a home-based service. So maybe they're not physically in the home, but they will be located within a very quick driving distance so they can respond more quickly.
Thank you, Nolita. And you know, one of the things I'm so grateful for having Kids Mental Health Pierce County for was, I think when the pandemic hit, we were able to mobilize really quickly and be able to collaborate and share ideas to say, how are we going to respond during the pandemic? How are we going to provide these crisis supports? Can you talk a little bit of how crisis support looks with confidentiality, using it in a virtual format with telehealth?
Who are you talking to?
Anybody who wants to add to that.
Okay, I can jump in and say something. One of the things, and obviously this is something that gets tricky, that we did understand from the beginning, like there's some things, and not so much around confidentiality, but like signing documents that we've been able to have like with the people that oversee that and will audit us, that we have a little more flexibility about getting like electronic signatures, or sometimes you can even write verbal consent for some things because shuffling paperwork around can be a little bit trickier. What we try to do with the virtual, and I will tell you it's hard, is we immediately say, hey, who's in the room with you? Kind of like in the same courtesy that we try to give, I think, all of us when we're doing a conference call. If we have somebody on speakerphone, we say this person's in the room or so-and-so just walked in the room. So we're trying to establish asking that from the very beginning. Is this somewhere you feel like you can talk? Sometimes if we have because we work in teams a lot of times, and having 4 people go in the home isn't going to work. So one person's like located in the home and they can move the laptop or the tablet, whatever device, and try to get somewhere that's a little more private. It's tricky. I've been a part of doing that as well. Is it quiet enough upstairs, even though everyone's downstairs, there's no door closed? And then we try to set people up in the beginning. If we're doing telehealth, okay, are there places that people can go? If we want to have time where we're just talking to the adolescent or talking to the caregivers, are you going to be able to go somewhere that's safe if there's supervision needs, or do we have to figure out a way that someone's there supervising so you can be in your bedroom talking to the clinician or the parent peer, which is something I forgot to mention earlier, that we do have youth and parent peers as a part of our team, in addition to some paraprofessionals who are providing these levels of support. Definitely asking people if they're comfortable with this. Is this okay? Does this feel private enough for you? if some things are coming up and they're talking, we might stop them because maybe this isn't something that we want your 7-year-old son who might be so climbing on you, even though we're talking about your 14-year-old daughter. Maybe these aren't the things that we want to talk about right now with them sitting next to you. But we establish that in the beginning and then go over it as the call is initiated. And then obviously we're trying to pay attention to the environment as much as we can, where if we see another kid coming on camera and they hadn't mentioned that we try to address that in the moment. So sorry, I don't want to take up too much of the time. There you go, you guys.
Thank you. Adam or Todd, did you want to add anything to that?
I think that in our situation, things are differently, and maybe I didn't clarify that. Generally, when there's an IT investigation, HIPAA, any sort of like that kind of like gets paused for the duration. So the moment we accept the referral, we can kind of delve in and talk to anybody on behalf of the patient up until the point we detain or don't detain. So HIPAA really is not really kind of our area. We do support it in other means. We do electronic documentation. We do have the ability to do life size, so it's all virtual. The investigation if need be, I guess.
Thank you. And I know through this pandemic, we have really had to get creative and think outside the box on a lot of different things. Do any of you guys have any recommendations on some creative ways for students to stay active now with the additional shut-ins, not going to school and the inclement weather? Any things that you guys have heard that's been really successful and engaging in families in that way?
I mean, I could just say this is more for our ongoing services. We've tried to do things like, so something that some of us have done is like, as much as we can get outside, like walking while we're meeting with people. Because one of the worries is that people are on screens all day. And I will tell you, it's a big struggle and I think everyone on this call could probably echo this, that a lot of even some of the calls that we're getting pulled into is because people are shutting down or melting down. People used to like school don't like it. It's hard, it's confusing. And so anything we could do to get these bodies moving, and if we're walking outside, and sometimes it's actually more comfortable for people to talk. We're both facing forward. We're not staring at them like you're getting counseling now. So it actually can loosen them up, and you're out with the trees or the fresh air. It's also safer in terms of the COVID pieces. We've had things like we've met people, like let's say at a school, because they're closed down, like people are on each end of the football field and doing exercises, especially in the early days where we were really trying to be as remote as possible. So we could still meet and see folks. Sometimes we do things like where we're driving, in the car, and then we're meeting them there, and we're socially distanced. Trying to do activities. Sometimes they can do an activity on their screen. We'll do one on ours. I'm not saying these are all super successful. Moving tends to be something that we get better outcomes for, better results, but and we actually meet as an office every Monday morning. And we have a whole kind of teams group dedicated to creative strategy. So things that people find, things that people have found successful to engage. Maybe doing something where we would just traditionally maybe have a session with a family at home. We do it more as a game because people are kind of in a pressure cooker at home a lot. So we can introduce these kind of clinical strategies and themes, but do it through kind of an avenue of a therapeutic game, or bringing therapeutic things even to a normal game that people might do. I don't know if that's helpful.
I think it's helpful. Julie, Adam, do you have anything that you want to add? Todd?
I don't have a ton to add, except, just as a parent of kids that are 12 and 15, just getting them to get out of the house even 30 minutes a day. We live in the Pacific Northwest, like bring an umbrella or just, embrace the rain. But I just think getting outside your house is so important for everyone, whether it's a walk or a bike ride or a scooter or whatever.
Thank you. And I did want to address, there was a question that came up a couple of times about accessing intensive services when you have private insurance. I would highly recommend that you go on the kidsmentalhealthpiercecounty.org website. There is an insurance resource. A lot of insurance companies have behavioral health case managers that you can access. Every plan is a little bit different, but they're able to assist with locating and letting you know what contracted providers that your service provides. With some insurances as well, you you can ask for single case agreements to contract with certain companies. It just really depends, but I would definitely contact your insurance company to really see what services that you're able to access. Nolita, Adam, Julie, do you guys have any other ideas on that in terms of other intensive outpatient services for non-Medicaid kids?
I will just say, I was actually going to type that it's probably one of our biggest concerns and one of the top things that we tend to bring to the table. They're absolutely resources. We have reached out more than we ever have to private insurance companies. We've actually had a few meetings as an organization to try to see what we can do. I mean, I won't get into all the stuff, the problems with billing and the way their structure works and how it doesn't, we're just a round peg in a square hole in terms of the type of work we do. Obviously, there's lots of good organizations doing lots of great work out there. And so I love that you have that resource, Ashley. But in terms of like the services that we in particular provide outside of crisis, we used to be able to do it with FAST, and it's changed since the beginning of 2019.
Yeah. Yeah, thank you. Definitely a complicated question, and just know that our website has some of those resources, and we also have a multidisciplinary team that anybody in Pierce County can access and make referral to for complex behavioral health presentations or multi-system navigation. Don't feel like you have to navigate the system alone. United Way 211 also has behavioral health navigators that have the most up-to-date database of behavioral health providers. So those are all great resources to help you navigate this really complex system. So don't feel like you're on your own, and please check out those resources. There is a couple of questions about WISE, which I felt like was a good segue for me to let everybody know about our next December webinar. Is actually going to go into wraparound with intensive services, or WISE. So WISE is a service that we have for children who are Medicaid eligible, and we will go over the elements of WISE, as well as you'll be able to hear from our 3 WISE providers. We do have 3 WISE providers now here in Pierce County, and hear about their different programming and be able to ask questions and answers. So save the date. It's going to be Wednesday, December 16th at 3 p.m. We will have information on that on our website. Hopefully next week you'll be able to register. If we were not able to get to your question today, please feel free to email me directly, and I'm happy to connect you with any of our panelists or point you in the right direction. Again, this is really a community effort. This is a community collaborative. These are really all of our kids, and it's going to take all of us to really rally around kids to get them through all the changes that they're enduring and all the things that families are going through. So I appreciate your time. If you are interested in participating in a future webinar, if you have ideas for a future webinar, please don't hesitate to reach out to me. Again, here is my information. Here's my email, the website. I'm happy to talk to you about any of your ideas or questions. So if there's nothing else, I want to thank all my amazing panelists for showing up and doing a great job with such a low amount of time with a lot of content. And I want to thank all of you for being here. Again, we'll record this. Tell a friend about it, email a friend about it, follow us on Facebook, check out the website, sign up for our newsletter. And thank you all for being here, and have a great rest of your day.
Yes.